For the assignment of the module Contemporary Issues in Medicine Practice, I have chosen to talk about the future implementation of the direct access to physiotherapy for musculoskeletal disorders in Switzerland and have an emphasis on diagnosis of the physiotherapists. I'm going to start with a quick presentation of who I am and what pushes me to talk about direct access in physiotherapy. I live in Lausanne, a city of the French-speaking part of Switzerland, and I'm Swiss. I work as a self-employed physiotherapist in outpatient musculoskeletal practice. With the help of a postgraduate training, I'm specialized in musculoskeletal management and manual therapy. I'm part of the master course Advanced Clinical Practice for Musculoskeletal Management, and I am a teacher in musculoskeletal management in one university of applied science. I encounter some issues in my daily practice as a physiotherapist underpinning my reflection for this work. The first one is the regularity of incomplete diagnosis coming from the referring doctor. This often leads to an inadequate patient's pathway or management, like unnecessary surgery, etc. And what I find very difficult is the confrontation of my diagnosis, my opinion about the management of the condition with the doctor's diagnosis. Sometimes I'm struggling with the patient who would prefer to have one opinion. It's about the balance between not to make the doctor's opinion incredible and what is best for the patient. To explain my choice, we should have a look at the context of direct access to physiotherapy in musculoskeletal management. According to Briggs and colleagues in their well-documented report about the burden of musculoskeletal disorders in healthcare, musculoskeletal conditions are the leading cause of care seeking in primary care. This participates to put some pressure on healthcare system and has consequences on patient participation in work and social life. It increases the risk of chronic conditions development, and it has economic consequences. To face that, as the World Physiotherapy mentions it, there is an evident necessity for more efficient pathway and redistribution of healthcare system responsibilities. In this sense, the implementation of direct access to physiotherapy for musculoskeletal disorders has a twin goal of optimizing musculoskeletal care and strengthening the profession's autonomy. If we have a look at what is made in Switzerland, we should refer to the federal action plan called Santé 2030. It is oriented on four main challenges which are the use of the technologies and digitalized health to improve health efficiency, the demographic and social evolution with a focus on health promotion among children, the quality of healthcare and financial issues, and finally, the right to live in a healthy environment. It's interesting to consider that there is nothing about promoting advanced practice and that it stays vague about interprofessionality implementation. Even if there is an identification of the need for change and a relevant analysis of the factor to modify, no concrete proposition is made. This lack of engagement and concrete proposition from the Confederation can be explained by the protection of the economic and private health insurance system. It's not a secret that Switzerland has a strong economy-oriented politics. A second point to consider is that the political system in Switzerland is not organized around a strong central government. The workforce plan may stay quite broad to let the possibility to the cantons to modify their policies in regional jurisdiction. Now, if we have a look in details about physiotherapy in Switzerland, concerning the direct access, I have found a very interesting file dating from 2022. A politician put forward a motion to the Federal Council about direct access to physiotherapy as a solution to manage healthcare costs. The answer is very clear, and it says that the insurance system repayment relies on doctors' monopoly in terms of diagnosis and prescription, and according to the Federal Council, broaden the direct access to other healthcare providers may cause an increase of health costs without any benefits on patients' health. This example shows the strong health insurance lobby and politics in Switzerland. We have here a good example of how cultural influences as medical dominance in neoliberal view maintain a political system and vice versa. This environment does not seem ideal for the development of autonomous practice of physiotherapy. With this information, I asked myself, is the answer only due to cultural and political issues, or is there a good medical reason not to trust in diagnosis performed by physiotherapists? To answer that, we should have a look at the accuracy of diagnosis. If we compare diagnosis accuracy between extended scope physiotherapists and orthopedic surgeons, we can see that the performance is identical. In the two systematic reviews presented here, few RCTs are included, but the sample of patients is quite large, with more than 1,000 patients. The study of Moore and colleagues is quite old, but the strength is that they compare the accuracy of the diagnosis with MRI results. And MRI is the gold standard to diagnose most of the musculoskeletal conditions. To go further, the systematic review of La France and colleagues concluded that the diagnosis performed by APP is more accurate than GPs or non-musculoskeletal specialists. In this review, most of the included studies are cohorts, which is not the highest level of evidence, but may not be qualified as poor quality. Finally, in the Swiss context, Keller and colleagues tested the accuracy of 1,500 Swiss physiotherapists' diagnosis with musculoskeletal clinical cases. They concluded that higher level of education, meaning physiotherapy education, permits to elaborate more correct diagnosis and decision-making. But an interesting point is that over 10 years of practice, the diagnosis is less accurate, even if the clinical management remains correct. We can conclude that the accuracy of the diagnosis is directly linked to specific training for the management of musculoskeletal conditions. Concerning safety of direct access, no adverse event has been reported with direct access model of care in a sample of more than 50,000 patients. What is to discuss here is that there is no clear definition of what is an adverse event, which may have very different consequences depending on what we're talking about. A last point to consider is the fact that the rate of serious pathologies masquerading in musculoskeletal conditions is very low, so if direct access to physiotherapy is allowed for musculoskeletal conditions, the risk to miss a serious pathology is also very low. So, we have seen that direct access is safe and accurate, but to have a complete view, it's important to consider the perspective of the physiotherapists who experienced it. 3 studies have been chosen to illustrate this topic. They are all qualitative studies conducted among first contact practitioners in the NHS. Even if the sample is not very diversified and thus the transferability of the findings may be contested, the context is very similar to my own practice, and the quality of the methodologies and its accurate application with data saturation increases the trustworthiness of the results. The first point to consider is uncertainty. Uncertainty is the tolerance of ambiguity within the clinical decision-making. This topic is expressed through the fear of missing serious pathology and the lack of knowledge concerning the management of non-musculoskeletal conditions. This is linked with patient safety concerns in addition to a feeling of pressure. Directly linked to uncertainty is the accountability about diagnosis making. It is lived as a burden of responsibility, as the physiotherapist is the first person to see the patient without any prior information or screening. The fear of medical legal consequences in case of error is considered as a burden disrupting the diagnosing process. This may cause a feeling of isolation among first contact practitioners, which may progress in a feeling of burnout and its well-known consequences. The last point noted by the first contact practitioner is the time pressure. this topic has been strongly linked to uncertainty. As the most take decision in short time lapse, they use more likely diagnosis strategies as gut feeling or pattern recognition to facilitate the speed of thoughts. But it is known that these strategies are more associated with an increased risk of diagnostic error and an increased feeling of uncertainty. It is interesting to note that first contact practitioners report the importance of specific training, but also context-dependent training focused on the ability to take quick decisions in a short time and under pressure. We can see that first contact practitioners' perspective on diagnosis in musculoskeletal care relies on two main concerns: the patient safety and their own well-being. It's interesting to consider that specific training seems to be one of the key points to take into account concerning diagnosis making in an FCP role, but also that there is a need for social support. We have seen that even if the prevalence of serious pathology masquerading as musculoskeletal condition is very low and that no adverse event can be reported, uncertainty concerning an adequate diagnosis is very present among FCPs. And this has an impact on physiotherapists' well-being and professional durability. To go a bit further in the analysis of uncertainty, we can see that the main impact of it is the risk to develop defensive medicine. According to Finucane and colleagues, it is defined as the practice of an overcautious management of patients to reassure clinicians and to mitigate the risk of medical legal claims. It may refer to over-investigations, unnecessary appointments, additional intervention, or unnecessary drug prescription. The use of defensive medicine leads to an important ethical issues in care because it is focused on the protection of the care provider and not on a patient-centered approach with shared decision-making. Besides, it may contribute to healthcare costs with the use of over-investigations, unnecessary treatment, etc. But above all, it may compromise patient safety because of unnecessary radiation, risk linked to invasive procedures, treatment, etc. Defensive medicine is directly linked to a medical culture oriented on performance and on avoiding errors and choosing what is right or what is wrong. It is well described in the literature that communication skills and shared decision-making process are central to adequate care. Also, it is interesting to consider that professionals using more likely shared decision-making process are less exposed to uncertainty. With the aim of implementing direct access model of care, here are some propositions which can be developed in Switzerland. My action plan is divided in 3 parts. The first is the adaptation of the entry-level curriculum with the following points: access to outpatient contextual placement and internship, use of simulation programs, educational outpatient clinics within the universities, and education, obviously, to uncertainty and decision-making. The second part is oriented on the needs for continuing education and long life learning. It's about specific training, strong leadership development, uncertainty management and coping strategies, partnership, and communication skills development, self-reflection development. And one important thing is that it could be very interesting to base it on international standard. In Switzerland, as we have seen, there are some cultural barriers to the implementation of direct access. An international training pathway based on IFROM standards, for example, would permit the physiotherapists to be trained and provide quality care and start a change in culture among patients. The third part is based on professional networks development and with clinical supervision, mentoring, peer supervision, and collective intelligence strategies. A very good example of this, and that is very well constructed, is the roadmap to practice constructed by the NHS. But even if it includes all the main points to develop physiotherapist abilities, we have seen that the shift of culture needed to strongly implement direct access to physiotherapy is coming very slowly, and thus a reflection about the experience of other stakeholders would be interesting to take into account. Here are my reference lists, and I thank you for your attention.